want to start off the conversation by talking about three bills that were introduced to the Texas legislature the last session. Texas legislature meets every 2 years. Last year was an action-packed legislative session. There's probably more bills introduced regarding healthcare than any other previous session that I'm aware of. So I picked out three bills I'm going to talk about today. Two of them passed and one of them didn't. But I think the theme behind these bills is that, in my opinion, they are government reactive to the market. So the market is really very innovative right now. It's very dynamic. I've never seen it move as fast as it's moving today. And the Texas legislature have taken note, and they have passed two of these bills, which I think could help solve health care for Texans. First one is House Bill 3752. It's designed to create more competition in the group health market, particularly in areas or geographic areas of Texas where there's a monopoly has been formed, where healthcare costs are going through the roof. They've changed the Texas insurance code to allow a company called Texas Mutual to offer a alternate health care plan to Texas employers of 250 employee lives or less. It'd be fully insured. That's going to offer some innovative things that we're already doing in the private market on a self-insured basis. To go back through memory lane, in the early 90s, Texas workers' compensation market was in turmoil. Costs were going up, very little competition. So the Texas legislature, in their genius, created a company called Texas Mutual to be the insurer of last resort to try to solve the issues and the problems of the workers' comp market. They were so successful that 2 years later, they refunded back to the state all the seed money that the state had provided to start the company. And eventually, Texas Mutual became a mutual insurance company owned by its policyholders. So next year, you're going to see Texas Mutual roll out some benefit plans for employer groups of 250 employees or less. It's going to include things, from what I hear, it's going to include things like reference-based pricing, cash pay at the point of service, direct primary care, risk transfer, the hospital financial assistance policies, and other innovative strategies that many in the room are already doing on a self-funded basis. The other bill is 484. It failed. 484 was designed to give better access and better experience to Medicaid recipients. Medicaid recipients have an access issue because fewer and fewer doctors are taking Medicaid, and the doctors that do, the wait lists are long. I'm going to point to a DPC company down in the lower Rio Grande Valley, Frontier, which is a real success story from what I can tell. They started in a little tiny, it wasn't long ago, 3 or 4 years ago, a little tiny bare office with a scale in it. No nurses, just one physician decided he'd had enough. And it was located in downtown Harlingen, Texas, in the La Placita area, which is a poor part of town. And that has since grown to 4 clinics, very modern, with a huge membership. So most of their clients, from my understanding, are Medicaid recipients that are willing to pay $60 a month to have better quality care, better access, and more time with their physician. That failed. But that's not going to stop the direct primary care movement in Texas. And the last bill I want to talk about is Senate Bill 1444, and this is the bill that proves that government can solve health care by getting out of it. Right? So I just proved you guys wrong. Senate Bill 1444, let me go back first and explain about the government health plan in Texas called TRS Active Care. It was started 20 years ago. It was designed as a safe harbor for school districts who were having trouble at that time getting health insurance. Over 90% of Texas school districts joined the TRS Active Care. And over time, the plan has not worked out well for them. They've been employing the same strategies since inception 20 years ago, which is traditional managed care status quo plans. They haven't changed it in 20 years. Costs have gone up, cost shifting has gone up. And about 5 or 6 years ago, many of the school districts that were members of the plan wanted to get out, but they couldn't. By statute, once they're in, they can't get out. So a little tiny school district in South Texas, in probably one of the poorest counties in Texas, decided that they were going to challenge TRS Active Care, and they found a loophole. in the education code that they thought would allow them to offer a companion or side-by-side commercial health care option. So they stepped out and they created a program that employed a lot of strategies that I think Texas Mutual are going to pick up on. Direct primary care, a primary care centric plan, risk transfer on specialty drugs, cash pay at the point of sale, claim adjudication, no access at all to managed care networks, all direct contracting. That plan was started September of 2019. A year later, other districts followed suit, and over 100 school districts in Texas decided that they were going to attach to that loophole as well, and they offered commercial health plans, often with rates better and better benefits than TRS Active Care, which is a large 450,000 life case. Texas legislature got wind of that. They realized that there may be a better way. So Senate Bill 1444, for the first time in 20 years, allows school districts to go out on their own and seek competitive commercial insurance. So this is an example of how government can solve healthcare by getting out of the way. I want to turn it over to Greg to see if he has any comments on it.
Yeah, so the Senate Bill 1444 created a lot of opportunities for consultants, brokers to get into this school district space where we've not been able to do so before. And that's our niche. We've been involved in that space in a lot of different areas in our company, from property and casualty to voluntary benefits, dental, vision, that sort of thing. And a few who had never been in, that 10% that had never been in the TRS Active Care pool. So what I wanted to chat with you about is, if you're thinking or you want to get into this public entity space, it is a different animal. The buying process is different. The decision makers are different. The influencers are different. Their motivations are different. So buying processes are long. They are typically done through formal RFPs, and which we're involved in as their consultant. We're typically writing those RFPs and providing them to the district so we can craft it so we get kind of the response that we're looking for. But it's a very different thing than a private employer through that process. And secondly, the decision making is really different. There's school boards. There are insurance committees that most schools will bring together a consortium of employees from all areas of the district, and maybe 50 people that get involved in this decision making. That's a really difficult path to navigate, because what we've learned is that most of those people care about one thing. That's my own personal situation, right? They're not thinking broadly about what's in the interest of the overall district. Secondly, employee input is listened to. All of these employees have some relationship with board members. They're talking offline. They like this. They don't like this. Decision making is really different. But the key to it, if you're doing innovative strategies, if you're just doing Blue Cross plans, it's no big deal. None of those people are going to get upset or get involved too much. But if you're doing innovative strategies that upset somebody's apple cart a little bit, you're going to hear through all these different channels, and you have to be prepared to manage that. And the number one key to successfully doing that is making sure that your key leaders are 100% on board. That's your superintendent, your heads of HR, your CFOs. If you can get that team, then they can influence the others. I mean, I can tell you a lot of different stories, but I was at a board meeting for a school district giving first quarter results of an innovative plan we've implemented. It's going great. It's really going well. But with any change, there's always a few little hiccups and wrinkles, and this one board member had been listening to a few of those folks, and he just ripped me a new one in an open public board meeting. But because my superintendent is 100% invested in what we're doing, I didn't have to say a word. I mean, I wasn't going to get in a fight with this guy in a public board meeting, but my superintendent stood up and responded to that. So your key leaders have to be on board with what you're trying to accomplish. Thirdly, the motivations are different. When we're talking to private sector employers and we're talking to CFOs, we're talking to CEOs, it's about health plan cost. Secondly, this is what it delivers to your employees that are better. When we're talking to school districts, that's reversed because most of them are on a defined contribution model, meaning they're going to contribute $350 or $400 or $500, whatever it is, per employee to their health plan, and they're going to continue to do that. So there's no financial savings really to the district. But what they are motivated by is the fact that the TRS plans they're on have continually gone up, the benefits have continually eroded, and public school employees get a 2% raise, maybe 3, maybe 1. And what's happened over the last 10 years that we've been working with schools is every year we see that their health plan costs exceeds the amount of their raise. So they're actually going backwards every single year. And so our talk to them is not about, we're going to save the school district a bunch of money. Our talk to them is, we're going to improve the lives of your employees and we're going to make their raises meaningful. We're going to reduce their out-of-pocket costs. We're going to reduce their premium costs, and we're going to make your employees' lives better. And that's a very different thing than what we typically talk about with public sector. Now, just to give you a couple of things that we're doing, it's typical of what you're going to hear in this room. We're self-funded through independent TPAs. Sometimes we're using narrow networks. Sometimes we're using physician-only networks. We have cases, direct hospital contracts that are, if it's a local, smaller community. We are doing some reference-based pricing, of course, PBM, all these things. And the result of that, and I'm going to give you a few numbers I didn't put on this slide, but our members are paying less premium. They're dramatically reducing out-of-pocket costs. I'm going to give you a couple of numbers just verbally. So far, we're about 8-9 months into our first school district case that we did under this program. And I'll give you some numbers on that. And our free market providers are being advantaged, they're being supported, and our employees are benefiting from that. So let me give you a couple of kind of case studies. We started one school, it's about 1,800 lives last September, so we only have 8 or 9 months of data at this point. But those employees through TRS, Active Care Program, all had a deductible around $3,500. Most of them had an out-of-pocket of about $7,900. We implemented a plan that had a $750 deductible, a $5,600 out-of-pocket at a lower price point, so that 100% of the employees are saving money every month on their premium. But that's not really the story. The story is that the 100% benefits that we have built into this plan, if they choose well, involve almost any outpatient surgery, virtually all of their imaging, thanks to green imaging, a lot of DME, all kinds of other services that these employees are not paying a single penny for. Through the first 4 or 5 months of our plan, Texas Free Market Surgery was our largest provider. The employees caught onto this thing, and employees were getting the surgeries they needed. And the reports we would hear back from HR is that particularly the lower paid employees were coming to them saying, hey, I've needed this surgery for 3 years. I could never afford it. Now I can get this. And I'm running out of time. I'm running through her time. But the second case study we implemented in January. They were already self-funded, but they were self-funded through an Aetna ASO program. We saw nothing but the cost escalate. We kept the benefit program basically the same, but we direct contracted with a local hospital and all the physicians that they own. So that's 100% benefit now. And then they also have access to all the other things we're doing. If they're willing to drive, it's a little bit of a haul to get to Austin to see Sean's team. but we're providing DME, we're providing imaging, we're providing all these other benefits at 100% cost, and we'll be able to track and see. But I just know already that each of these cases, their employees out-of-pocket spend has been cut by probably 75%. And the funding is far exceeding what we're needing. So the first case I talked about, they were funding it at rates lower than what the TRS rates were, but through the first 8 months, they've developed about 26% of their plan revenue in reserves, which is almost $2 million. Employees are better served. On the second one, this one's about 1,400 lives. Our per employee per month cost in 2021 with our Aetna ASO and their great contracts was $889. Through our first quarter, we're running about $675, which includes a big run-in from Aetna, so I actually expect that to get better. So this is what we're doing. It's a different buying process, but when you can get the senior leaders on board and engaged, it's possible. And the employees are benefiting and the school districts are benefiting. And now we're talking to other districts who see it as a competitive advantage because they're struggling to hire teachers. And so they're seeing implementing plans like this as a competitive advantage to attract and retain the employees that they need. So.
Thanks. Okay. I am the daughter of a Texas teacher and the granddaughter of 2 Texas teachers. And this, this matter is what's happening to people in traditional healthcare plans is getting worse and worse. And yet we have these great solutions out there. And it's really exciting to me to see this start to happen in our backyard because Carolyn Grant and I've been working on a school district in Florida together that green imaging alone, she has tremendous solutions across the board. The green imaging alone has saved the district and its members $4 million in the last 2 years. And so this needs to be happening in our state as well. Imaging is tough from the claims data standpoint, and if you ever look at it from an analytics company, you've really got to question whether it's accurate. I have TPAs that misrepresent the claims data all the time. In fact, most imaging claims now are 2 codes. So in order to compare green imaging prices to that in the traditional data set, we have to rebundle. We have to pull the professional and facility codes together. And now for a 3D mammogram, it's actually 4 codes that we have to pull together. There are also contrast codes, radiopharmaceutical codes, what Joe calls the J codes, but they're actually A codes and all kinds of other codes that we have to rebundle because all of that is in on our bundled pricing. I really thought hospital transparency was going to create a downward trend in what imaging costs in a health plan. And I have been shocked that it is not. Actually, private equity in my field, I'm a radiologist, private equity in my field is driving up the cost dramatically of imaging. 2 things are happening. Number one, the radiology groups have aggregated and private equity-backed radiology super groups. And they're combining, the 140 practices contracts and billing out. We see these claims data sets where we've got twice as many professional fees as we do facility fees. We should have about 80% as many. So we know that they're holding those old claims, they're aggregating, reviewing these contracts, and then billing out under the best old contracts. And the results of that are, here's a mammogram. Again, the 3D mammogram has 4 codes we're rebundling. The ones over to the left are actually just 1 code each. And we have 3D professional codes being paid out over $900 in these health plans. And in my world, $250 to $425 is fair for a 3D mammogram. And, in this healthcare plan right here, this was $647, and that's not the highest we've seen, was the average 3D mammogram. So what happens here, depending on the plan design, is a woman who's got a MEC in her plan and is, getting screening mammography at 0 out of pocket, and a woman with her lump in her breast is going for this 3D mammogram and a breast ultrasound and paying, over $1,000 out of pocket with a high deductible healthcare plan. This is a shocker for everybody who's controlling advanced imaging costs. An ultrasound is typically not considered, complex or advanced imaging. In my world, an ultrasound costs $150 to $400. In this set of claims data with 6,000 ultrasounds, this is one of the most common exams performed in a health plan. And the average ultrasound was $1,381. That's more than a CT scan. CT, 250 to 600 is fair in my world. The average for this client was 1072, which actually is not that bad. We're typically seeing about 1,400. As you see down here, we've got a member cost, member paying over $3,000 or almost $3,000, and the plan paying $6,000 for a single ultrasound. 3T MRI without and with contrast, $500, $1,400. This is one where Baptist Hospital in Miami, the technical fee alone, the facility fee was $6,200, the professional $478. I, as a radiologist, get paid about $60 to read an MRI. This one, $478, and it's not going to the radiologist. It's going to the private equity-backed group. PET CT, this is actually their pricing. Ours, which is bundled with the radio tracer, $1,400 to $3,000. The average for this client for the facility fee alone, not the radio tracer, was over $10,000. And then this was an interesting one. This is a reference-based pricing plan. They had great cost containment across the board on their imaging, except for the HCPCS codes. And so CT contrast, which is about a $15 expense, it's going up because there's a international shortage of contrast, but $15 expense to the hospital or imaging center. One claim was paid out at $390 and the other was at $7,900. So we're seeing also not just horrible pricing in the traditional healthcare plans, we're also, when Green Imaging has a patient who's a covered life that we don't have a contracted facility for, we go out and find the lowest cost, highest quality exam. And so we're continuously shopping for care. And so we're, hospitals have been asked to do this, and we're going to be mandated all doing our good faith estimates, they're putting other barriers in the way of getting those. They'll discuss with the client only, not an advocate. And this one is really interesting. If the patient has insurance on file, they're telling the advocate or the patient themselves that they cannot be self-pay. And that's actually that's a violation of the HIPAA omnibus law. And there's actually, somebody told me last night that there's actually a software program that they're using, and going in, they can get the third-party data and see whether even if the patient has not been to their facility and has insurance information on file, they can see if that patient has historically had insurance, and are enforcing this across the board. If they don't offer global pricing, if they don't have a bundled price, they're not disclosing who the professional fee will be handled through, whether it's a cardiology group for cardiac testing or a radiology group for other imaging. They're not disclosing who will be reading the study, or they say they don't know who will be reading the study, so you can't negotiate the other end of the price. Radiologists are frequently now not comparing to a prior exam unless it's a specific request from the doctor. To save time, they're on that dashboard, trying to read as many MRIs as they can, and they're not even doing routine comparisons. We see where we can only get a fair, a fair market price or a good faith estimate through email, and frequently that takes days and days to get. They're asking patients to give the CPT code, the code, the code that is published for that exam. They won't give them a good faith estimate unless they have the CPT code. Do you know how few patients have that knowledge? I guess the last one I'll talk about is they're also requiring re-imaging. This is a situation where if it does not come from that hospital system and a patient is admitted for cancer therapy, they won't honor the outpatient imaging that was performed. They're actually demanding that they be re-imaged. That's a real ethical problem when you're talking about radiation. We are finding that a really innovative plan Plan design matters. You can put things in place. You can put reference-based pricing in place. You can put copays in place. You can do things that really impact the amount, the steerage and the savings. And, with the school district of Osceola County, where it was zero out of pocket to the employees if they go to green imaging, they were initially subject to their Cigna copay and deductible if they went elsewhere. We've gotten tremendous steerage, and the employees know how to use us, and they come back to us. And the district has asked that we add endoscopy and colonoscopy because the patients know, how to access us, and have had great success with us. And so, that's a tremendously successful plan design. We have a similar size district, another near 10,000 member district in the Houston area, where the care is only accessible, the zero out-of-pocket imaging is only accessible through the near-site clinic. In that case, we get a small fraction of the steerage, and the savings are nowhere near what they've been. And the final one is, let's talk about a $275 copay for imaging. Most people in this country don't have $400 for a healthcare expense. And what we're finding is that a dramatic percentage of the time, people are going without care and delaying care. And there are huge cost implications of that, both in cost of quality of life and healthcare, and also in employer costs down the line for these delayed diagnoses. And so, really think about the plan design. A $275 copay would seem to not be prohibitive to many of us, and it is dramatic. We find that when that plan design is in place, we get about 5% of the steerage we do when we have a zero out-of-pocket or a low copay. It's something that somebody can truly afford. And so, your plan, you can't stick old school stuff into these healthcare plans and get the desired results. It really takes taking a leap of faith and knowing that, we're going to save, there's not going to be those $3,000 mammograms, and that's going to save both the plan and the patient money. And the other thing is, with a lot of the zero out-of-pocket design, it's not going against their deductible. And so we're not only, saving cost, we're keeping that patient from meeting their deductible with just one of these PET CTs. So that the rest of the care for the year is covered by the plan. And so, there are a lot of thought processes that need to go into plan design. A lot of creativity needs to go into plan design. You got to be flexible. You got to, when there's a new great idea out there, do a plan amendment, do some things that really enable the health plan to be nimble, because it really does matter. Those are dramatically different outcomes with those different plan designs.